So when we look at patients, we've talked about them having chest pain, and we talked about them having difficulty breathing, increased respiratory rate, tripoding. A lot of things we've already mentioned, using accessory muscles. All that should sound familiar, right? You use accessory muscles, you use that abdomen to breathe. We got a good example of that the other day in the ER with the B-Day class. This person coming in, trouble breathing, belly breather. If he wasn't a DNR, they were going to intubate him because he was just struggling too much to breathe. And he was using these accessory muscles. He was decreasing his mental status, probably because of some hypoxia going on. All right. He was quite large. He was what they refer to as morbidly obese. Y'all heard that term before? Yeah. That means that your life expectancy is not very long with that patient being that heavy. No matter how big you are, your heart is still the same size as your fist. All right. So if you, like this patient, he was probably, I guess he was 300 pounds overweight.
Oh my God.
So they turned that morbidly obese. All I'm bringing this up, not to bag on the poor man, but just saying that in the problem that he had with his respiratory effort, a lot of it dealt with him being so overweight. When you lay supine, all that blubber and everything constricts your diaphragm, constricts your lungs, When whales or beets, they don't have a good time just because they're out of water, they are, that's not what they're supposed to do. And to lay there. So anybody that's overweight, extremely overweight like that, when you lay them flat, there's problems. The other problem is, might as well had a DNR, because if he would have went into cardiac arrest, there was no resuscitating someone that big. If you note that as they lay flat, you try, but as a person that's morbidly obese like that, when they lay flat, their chest is at an angle. So if my hand was their chest, my fingers were their head, their chest is at an angle like this. Not like people who are within their weight standards lay flat. They're laying at an angle. So when you start doing compressions, you're doing the compression at an angle, and you're not getting hardly any coronary perfusion pressure because you're not compressing the heart. So anyway, a lot of problems there, but this guy's main problem was he was having some difficulty breathing, and we'll look at some of that. Like we said before, to know what's inadequate or abnormal, we have to know what's normal, right? Always keep in mind. So normal breathing is probably the way that we're breathing now. I don't see anybody in any respiratory distress. We're all have the ability to speak in full sentences. I'm not having to take a breath every minute or every word that I say. I don't have to stop and take a breath like that. That would be a sign of respiratory distress. Right? Normal, I guess it's bad on the big guy day, but a person of that size is always in some sort of respiratory distress because they can't speak in long paragraphs. They have to stop and take breaths because their heart is working so hard. We're all warm, pink, and dry. We have no altered level of consciousness. We're alert and oriented times person, place, time, and event. So that's sort of the norm. Then you look at the rates, 12 to 20 for the adult. Of course, we know that. Eventually, we'll have to know these for the infant and child. It's very important to make sure that you know all the normal rates. But for the most part, I just told you guys responsible for adults. The breathing is usually, we have a regular pattern. We have symmetrical rise and fall of the chest, in and out. Usually the rhythm is it's called I to E time. inspiration to expiration. Usually have a 2-second inspiration and a 1-second expiration. So you have a 2-to-1 I to E, inspiration to expiration. When those get irregular, that's a problem. And they get irregular for a number of problems that we'll see. Number of different breathing patterns. Like a head injury patient will have an abnormal rhythm. A diabetic who has what's called Kussmaul respirations are deep and fast because they're trying to get rid of the acidity. Alright? So you have different rhythms there, just like heart rhythms. And then breath sounds. We listen to wheezes, right, and rales and ronchi. Still didn't bring that Coke can in and listen to that bubbly sound, but oh well, not that organized. But rales, ronchi, wheezes, those are the Strider, those are the ones we picked up so far, right? And so, but we have clear lung sounds. You guys should have already listened to each other's lung sounds by now, or listened to some lung sounds. So this is a good picture of this guy. He sort of, they're making him up. They look sort of they're trying to get him to tripod, and they must have sprayed some water on him, or they took a quick shot of someone in respiratory distress. But see the way he's sort of diaphoretic, and he's maybe a little pale, flushed perhaps, depends on his gig, but he's definitely tripoded. So that's not a bad picture, sort of to see someone in respiratory distress. As you go through your time in the hospital, you're going to see people in respiratory distress. So you won't need pictures. You'll have a picture up here. Once you see a diabetic or smell a diabetic with ketones or that fruity odor smell, you won't have to imagine that anymore. You'll have it sunk in your memory. My least favorite is the GI bleed. Once you smell a GI bleed, you won't have to ever wonder what that hideous smell is like again, right? So it's good to get these mental pictures of what's taking place because you know it's normal. You see that, and sort of get a picture of these abnormal events. It's very important. It's that simple too, actually. Normal, abnormal, signs and symptoms. And then you base all that on the information and knowledge that you have, and you come up with the diagnosis. It's really not that difficult. For about 85 to 90% of the things, there's a good 10% of people who get sick that they just can't figure out what's wrong with them. That's when all the specialists come in and try to figure out what in the world's going on, right? So those are that. Remember, subjective. Patients' information perception is very subjective. I've been to patients' houses before. The complaint was difficulty breathing, but when we walk in the house, the patient, okay, the one that they called 911 for, was screaming at the top of her lungs, cussing at her daughter. You know, she was sitting on the floor, but she was still screaming at her daughter. So when I came in, my perception was, well, who's the one that's having difficulty breathing? That's what we're here for. And Granny on the floor said, well, it's me. It's like, well, you don't look like you're having any trouble breathing. You're screaming at this poor lady here. Then she hops up like some sort of ninja. I mean, this lady was 70-ish years old. She hops up and then she turns all of her attention to me and starts cussing at me and calling me everything in the book, telling me to get out of her house in so many different words, right? And I look at her like, well, you're not having any trouble breathing. I mean, we left, you know. I mean, this is some sort of domestic thing that you're having with your daughter, and somehow you call an ambulance for it. I don't know how all that works out, but you're not having trouble breathing because she could say probably 75 cuss words, you know, without taking a breath. And they were all at me. I mean, they called me everything in the book, but that's okay. I didn't lose any sleep over it. So it's subjective, But one thing that you don't want to do here is you want to be sure that the patient's telling you they're having trouble breathing, especially an asthmatic, that you sort of listen. And you sort of think, well, let's examine that a little bit more. Because the asthmatic may not look like they're having this trouble breathing, but because in asthma, they can get air in, they just can't get air out. So they may not necessarily look like they're having a lot of trouble, but you don't hear any lung sounds. Silence is deadly in lungs. But to hear a wheeze is a good thing. To hear nothing is a bad thing. So so you have to sort of take it all in, when you look there. So they feel labored, they can't get air in, all right? And like I said, their amount of distress may not necessarily correlate with what you see, all right? Always use the OPQRST. We use it as a pain scale, but we use it here as well. When did this difficulty breathing begin? What were you doing? Did you get stung by a bee? Is it related to allergic reaction? Were you smoking that 700th cigarette today? Is that what it is? Do you have a cough? Have you been coughing anything up? Is it discolored? If you're coughing and you're having a productive cough, or you're coughing something up, is that discolored? All right? So we all use these things, and there's a list of questions that I'm going to try my best to get out to you guys in these assessment questions to help you, to sort of guide you in the type of questions to ask. Do you have any pain? If you have any pain, does it radiate? On a scale of 1 to 10 with breathing, I don't really use that. That's just too much. It's too subjective. I just go the words per breath. It's a better indicator. So when I'm talking to the patient, are they saying, do they have 2-word sentences before they need to take a breath? Are they going, and take a breath, and, like that? And to get these pauses where they have to take a breath every 2 or 3 words, that's an indication of difficulty breathing. I speak typically, I think they timed it one time at 80, 90 words per minute. I don't know how we got chasing that rabbit, but if I was having trouble breathing, then I couldn't speak at that rate. Couldn't speak at a normal rate. And then, how long has this been going on? That's an indicator. Important, if it's been going on a couple of weeks, then it's probably not that emergent. If it's 5 minutes and you can't breathe and feels like you're dying of lack of oxygen, then that's more of emergent, right? So use that OPQRST. That's a very good scale. Your observation is very important. Are they having any altered mental status, which usually equals to some hypoxia? Emphysema patients will have this big barrel chest. You can pick out emphysema patients in Walmart. When we go there in a few weeks to do our over-the-counter thing that we always do and eat it, you can pick people out in the store that have emphysema because these people are really skinny, their face is real thin, they're red, and they have this big barreled chest from all the expansion. Just like, almost remember Starling's Law we talked about the other day, the stretching out of the heart and the hypertrophic heart. They get this hypertrophic chest. It just sort of sticks out there in a big old barreled chest and real skinny, rib skinny. You can see them. So do they have this unusual anatomy? Are they tripoding? Leaning forward? Do they need to get their feet off of off the bed to get them upright, to get that chest wall expanded? So observation's important. Look at that. Are they having retractions, in their neck? The use of these accessory muscles, the belly. Remember, adults are not belly breathers, and we're nose breathers. Are their mouths open? Are they breathing through their nose? That might be normal for them. But still, they breathe in. Nostrils flared, that's sort of weird when you have to sort of go. No nostril flaring. But the nostrils will flare out. Pursed lips, that's a sign of these chronic bronchitis people. They like a fish, a goldfish, they sort of do that thing with their lips, and somehow it helps them draw air in. And then, again, number of words that they speak without having to stop. It's very important.
Everybody can sing on Disney Channel.
Yeah. Other things to look at, the other thing to look at is pale, cyanotic, flushed skin with these emphysema patient, pedal edema, we talked about that, sacral edema, where's that at? Sacrum, right. Get some edema back in here, the coughing. When we cough, we try to cough up. We cough because you have obstructions there. It's getting into the cold and flu seasons. We're going to start coughing because we have mucus, we have phlegm, the heaters are going to start coming on. We have dust mites and things that get in our respiratory tract that we cough to try to get rid of those. That's why we have that coughing mechanism there. Then the abnormal breath sounds, wheezing, audible, heard without the stethoscope, so you can hear them wheeze without using your stethoscope. So if you use your stethoscope, they're obviously wheezing. All right. So when you do this, when you're listening to those lung sounds, you're listening for the wheezes and the abnormal sounds, but you're also listening for decreased breath sounds. So do they have decreased breath sounds? Do you hear wheezes in some areas? Quiet in some areas? Quiet is bad. Okay, with breathing. The gurgling sound would be the rales or rhonchi. Snoring respirations or the stridor. Crowing is a thing that I always forget. I can never remember certain things, and I can't remember what crowing is. It's sort of a seesaw back and forth thing that pediatrics do, but I never used that term, so I'm not really sure what it is. I'll have to look it up. So auscultate, make sure that you compare one side to the other side, up top and down at the bottom. You can listen in the middle as well. It's like the student said that yesterday was trying to listen to this guy's breath sounds, and he was sort of on his side, and they tried to listen over here, and they stretched around instead of going on the other side, and they were just listening to abdomen. His abdomen had shifted over here, and so when they were listening, all they were listening to was probably bowel sounds. Because his lateral part of his thorax was covered up by his abdomen, or his girth, whatever you want to call it. So listen to inspiration, expiration, compare each side together. All right? The wheezes and the crackles or the rales, we talked about that just the other day. We listen to wheezes. This will be more prominent when we talk about asthma patients here in a couple minutes. We've already spoke of crackles and rhonchi. It just sort of gives you the definitions of them. Stridor, that sound maybe a partial airway obstruction. People get with stridor when they get a lot of phlegm built up in there too. They're trying to cough up that phlegm, and you get that partial airway obstruction. Make sure always that you get a good room air SpO2. Before we put them on oxygen, just put the SpO2 monitor on. Make sure that we have a good room air SpO2. Also remember, make sure that the heart rate on the pulse oximeter matches or is very close to the pulse rate that the mechanical pulse rate, one that you feel during your assessment. These have to match. A lot of times, a low pulse ox doesn't really mean too much. So you over a period of time, you're going to have to judge that, whether that's bad or whether that's good. Like an asthmatic will have a good pulse oximetry in the beginning because they're not having trouble getting air in, right? Yeah, so they don't be 100%, but they're in severe respiratory distress. So this is just a guide that's going to give you a number, but you're going to have to be careful. You don't have to evaluate that. Right? And once you evaluate that SpO2, then You know what I'm saying? Is that accurate? You know? And then I think it's, oh, I thought it gave you some numbers there. 15, anyone with difficulty breathing, remember the indications for a non-rebreather is someone in moderate to severe respiratory distress. So moderate to severe respiratory distress, 10 to 15 liters per minute. Don't put it on a non-rebreather. What's the indication for a nasal cannula?
It's a mild distress.
Right, mild respiratory distress. In the liter flow?
1 to 6.
Yeah. 2 to 6? Yeah. 2 to 6 liters per minute. So there's your two choices. Non-rebreather, nasal cannula. So 10 to 15 liters per minute, 2 to 6 liters. Remember, you're increasing that oxygen percentage. Even if they're at 100%, you still want to, if they're having trouble breathing, you give them oxygen. I've seen that so many times. People will put them on, oh, you're at 100%, you're not having trouble breathing. Well, that's not true. You could still have trouble breathing and still be at 100% on your SpO2. You have to, again, sort of evaluate that patient with the trouble breathing. So let's look at some of the conditions right quick. Chronic obstructive pulmonary disease, or COPD, we've talked about that already. That's broad classification. Emphysema falls in there, chronic bronchitis, asthma, CHF, they all fall in that COPD because it's chronic over a period of time. And for you guys, make sure that you note this. The overwhelming majority of these cases are caused by cigarette smoking. If you haven't started smoking yet, stay far away from cigarette smoking. Right? It's a killer. And it's highly addictive. Don't even worry about vaping. All right? You know, everybody else now, they're trying to stop smoking, which is good, but they're vaping and they don't know, they're about to put that on the hot plate because they don't know exactly what's in that. So it is better than cigarette smoking. You don't get some of the carcinogenic type things, the nicotine and the tar and the arsenic that's in cigarette smoke, okay? But stay away from it. Because if you're not a smoker, here's probably what your lungs look like, depending on where you live in the world, all right? This over there, they're hyperinflated. That's why they look so big. Yeah, this is a smoker's lung on this side. You can see probably a growth right here. It is some sort of growth, just don't know what. A growth right there. Healthy lungs, okay? If you live in a high polluted area, then your lungs won't look like this, but it's going to have some blackening on it, okay? You just can't live in those high populated, high polluted areas and breathe that stuff in. But it's not near as bad. This is a lifelong smoker. Lung there.
That's a tumor look like on the lung.
That's probably a tumor, some sort of growth, cancer. Something. You're not, this blackness right in here, you don't want to diffuse through that. You don't have a heart trouble with diffusion. And what's the norm? Getting that oxygen in and out. So let's talk about the first one, chronic bronchitis. These guys have an excessive mucus production, and I think do I have a picture? Yeah. You get this sort of mucus production that's in the bronchioles that gets down into the alveolus. These guys they're the ones with the pursed lips. They're walking around. They're big. All the ones that I've seen, they're sweaty. I don't know why they're always so sweaty, but they're sweaty, walk around with the pursed lips. They're usually overweight. They have this chronic bronchitis. Everybody's probably had bronchitis by now, right? If you haven't had bronchitis, you haven't lived in Texas very long. Really? Oh. You probably had it and just not diagnosed with it. But anyway, you get this chest congestion, this mucous membrane, you coughing up the luge. Okay. It's a form of bronchitis. Bronchitis is inflammation of the bronchioles, right? And through that you get this mucus production. This chronic bronchitis is just over a period of time. They have chronic problems with it. We could get bronchitis, go to the doctor, get a shot, Z-Pack, go on our way. These guys live with it. So the good thing about where we're coming from, the treatment's the same. So you don't have to come up with a different treatment plan for chronic bronchitis, emphysema, and asthma. They're all the same. All right, for where you guys are sitting right now. It changes later in life depending on what kind of medicine you do, but same. So you get this inflammation, you get this excessive mucus production, and through this mucus production, they're always coughing. It's a productive cough, big and sweaty guys. It's typically what you see. Emphysema is more than likely more prominent. Emphysema breaks down the walls of the alveolus. You lose the elasticity of the lungs. You get what's called a bleb. These emphysema patients, and emphysema, they say it on the cigarette packet. Emphysema is directly related to cigarette smoking. So you get these blebs. Let me try to draw a bleb here for you. So you got this bronchial coming down, and you have all your alveolus right here, okay? Sort of like grapes. Remember, if you want an image, remember grapes, the vines, that come down and the little branches and everything. So you got these grapes and these alveolus. What happens with emphysema is it breaks down these walls, and then they get really thick. And we know with thick bronchioles, you can't get that diffusion. The diffusion just won't go through it anymore, okay? And you get this bleb, and what happens here, this thing just melts all together. All right, so you have like a gazillion alveolus, and through that tar and nicotine, these things melt together. All right? And then there's no diffusion taking place there. It's too thick. We're talking a little bit about a spontaneous pneumothorax, which is very common for cigarette smokers. What happens is they blow these blebs out. They blow a hole in one of those blebs, and it causes a pneumothorax. Called a simple pneumothorax. Right? So that's sort of the bleb-looking thing, and it just sort of melts all that together, then there's no diffusion that takes place. And also you lose the elasticity of the lungs. The lungs don't expand and contract the way that they used to. They get stiff. And we'll see that in that, when we go on that tour of all the pieces and parts. So, and then, like I said, it reduces the overall effectiveness of the breathing. But here's the big thing here. They build up, these emphysema patients, they build up a lot of CO2. That's what gives them the flushed skin. They're really red-faced, and they're not Indians. So they build up this CO2, and they're always sort of hypercarbic. Their CO2, what's the normal CO2?
21.
No, that's room air. 35 to 45? That's the normal CO2, is 35 to 45. These guys are always up here in the upper 40s. You get what's called the 50-50 club, and we'll go through that. We won't spend time on that right now because we'll get that in respiratory physiology where we start talking about the oxyhemoglobin curve. You guys are going to the hospital, you can ask the therapist if you go to respiratory. When they start drawing arterial blood gases or ABGs, you can say, they're having oxyhemoglobin curve, and these big-time smokers, they follow this 50-50 club, but they get really their CO2 gets, they retain this CO2 a lot, and they get hypercarbic. If you get too much CO2, you get this term called incompatibility with life. Incompatible with life. CO2 goes up too much, you can't live. Here, a long-term heavy smoker, probably like those lungs that we saw, they potentially could have to use their backup drive. We breathe, non-smokers, normal breathing people, okay, we breathe on what's called a hypercarbic drive. Hypercarbic drive. This is the primary drive that we breathe on. And we breathe in response to CO2. That's why hypercarbic, above carbon dioxide, carbon dioxide. So normally, the normal breathing is on the response to CO2. So when the body builds up CO2, we take a breath. That's the short version. We'll get the long version later. So the body recognizes that you have too much CO2, then boom, it's on a signal to the brain to take a breath. There's chemoreceptors and baroreceptors in the body that measure CO2 constantly, and we breathe in response to CO2. Alright? Very important. Normal breathing pattern. We breathe on a hypercarbic drive. We breathe in response to CO2. The severe emphysema patient may be breathing on their backup drive, which is the hypoxic drive. Now the hypoxic drive, these guys breathe on the response to oxygen. Start to put those pieces together, right? So what's the problem with that?
You can give them oxygen.
Why not?
Because their body already has enough, so they won't take it in and it's not help them breathe.
You're close. You gotta give them oxygen. What's the standard of care for someone having difficulty breathing?
Oxygen.
Oxygen, right. Give them oxygen. So if you don't give this patient oxygen, you're violating a standard of care. So you get in this sort of awkward position there, okay? But you're pretty close.
Do we have some drugs that make them stop?
Now, hypoxic drive, breathe on response to oxygen. They're having difficulty breathing and you're giving them oxygen. What flavor of oxygen are you giving them?
What do you mean by that?
That's right, non-rebreather. They're having severe respiratory distress, so you put a non-rebreather on them, which is 90 to 95% oxygen, right? They're normally breathing on 21% oxygen. Now, since they're having trouble breathing, and you give them a non-rebreather, which is the standard of care, at 90%, what's that telling the body? If they breathe on the response to oxygen, why would they stop breathing?
Because they breathe on an oxygen response, so their body would think that it already has more breathing. They won't take it anymore.
That's very good. I'm telling you, man, I just stayed home. You can come teach this. That's right. Con was exactly right. If you could hear her. We breathe on 21% oxygen. That's the normal response. These guys are breathing on their hypoxic drive. All of a sudden, you throw a non-rebreather on them at 90%, and the body's just sitting there going, sure, I don't need to breathe. I went from 21 to 90, right? That's like if you're hungry, you know, and you normally eat 21 calories a day, right? And this is your normal diet, and all of a sudden, well, you can put whatever number there you want, right? If your normal diet is 1,500 calories a day, all right, and then I don't know how many times, almost 4 times the amount of oxygen, right? So what's 15 times 3?
45.
Okay, well, let's use these numbers. If you're used to 1,500 calories a day, okay, and that got you by, and all of a sudden, boom, someone gave you 4,500 calories, you wouldn't feel the need to eat, right? Nobody in the world except Free Willy would feel the need to eat after eating 4,500 calories. Okay, so you don't have this need. The body goes in the same way. They're like, hey, I got plenty of oxygen because that's the response that I'm breathing off of. I got plenty of oxygen. Stop breathing. Now, is that a problem? Why is that a problem?
Please stop breathing.
Is respiratory arrest a problem?
Yes. Or actually.
I mean, overall, it's a little problem.
Just stop breathing.
Breathing's way overrated. But why is that not a problem?
You can breathe for them.
Exactly, we can breathe for them. So that's not a problem. These guys are no problem potentially stop breathing, but it's not a problem. We don't breathe for them. Alright? We don't get our bag valve mask out and start breathing for them. So we'll breathe for them. Because we have to give them oxygen, right? Now, later on we might pick up, I don't know if we ever go there, but later on we might pick that up. Intubation, you're sitting in the hospital. They don't want to intubate these emphysema patients. They don't put them on what they put this guy on that we were talking about earlier, BiPAP or CPAP. They don't force air into the lungs with this machine. That I'll just wait and let you experience when you get there. But instead of intubation, the problem with intubating in placing an emphysema patient and an asthmatic on a ventilator is they become very supportive of the ventilator, and they're very hard to get off the ventilator. So a lot of times when they intubate this type of patient here, they're putting them on the ventilator the rest of their lives, potentially. Very hard to wean them off the ventilator. Okay, so everybody sort of understands this, right? This process here. You got to give them oxygen. They're having difficulty breathing. They're breathing on a hypoxic drive. And most of the time these guys will tell you that because they say, my pulmonologist says, don't put me on that non-rebreather. What's a pulmonologist?
Specialize in breathing.
Specializes in breathing, or the lung doctor, right? But we still got to treat them. Now, the good thing about it is that we can sort of tell when this patient's going to stop breathing. So you can go ahead and get your bag valve mask out. Respiratory rate and heart rate are proportional. Respiratory rate goes up, heart rate goes up. Right? Respiratory rate goes down, heart rate goes down. So what we look for in this patient here is when the respiratory rate, because they're having trouble breathing, right, is elevated, and their heart rate starts to drop. You know, drop is in the bradycardic range. They drop down into a bradycardia. Respiratory rate's still up there, okay? Heart rate goes down. They're about to stop breathing. And that's on any patient. All right. So you notice that. You pick up these signs and like going, okay, we better do something here. This patient's don't stop breathing. Now, this patient here, you notice that. What could you do maybe to offset this respiratory arrest?
You can't give them oxygen.
Hmm?
You can't give them oxygen.
Now, you're already giving them oxygen. They're on a non-rebreather, and the respiratory rate's still up there. They're breathing 50 times per minute, but now they've dropped down in the heart rate of 60. And you're like, oh, I remember him telling me that. What could you do to offset this patient from going into respiratory arrest?
Take them off the non-rebreather? I don't know. Take them off the non-rebreather? I don't know.
That's right.
What?
Why would you take them off the non-rebreather?
Oh, to let real air go in.
You lessen the air and they breathe.
To make their heart beat.
To decrease this, right? Decrease this number of this oxygen in their system, right? So to decrease the amount of oxygen in their system, they're breathing on this hypoxic drive, so now the body's saying, oh yeah, I need oxygen, so I'm going to continue to breathe. All right? So those are just things, you won't have to be overly concerned with that. But that's just something that you might see in the emergency room as we go forward. And then there's a good picture of it. Air trapping. You get this air trapping in the alveolus. Some mucus production. This bronchoconstriction right here. You get this right through here as well with emphysema. Questions there? Everybody good with emphysema? Chronic bronchitis? Anybody have asthma? Wheezers? Yeah. So you're familiar with it. It's episodic, which means that these things are episodes. What brings on your asthma?
It was really bad. And if I laugh a lot, sometimes I get nervous.
Maybe we could tickle you and send you into an asthma attack. Take you to the team.
Especially when I get sick, I'll get bad. And I had take alcohol.
Albuterol? What about you?
Like, I think my first asthma attack was when I was running or something, and I accelerated too fast, and so I would like get short breaths, and then I would get kind of lightheaded, but once I calmed down, I was good, and I was on that inhaler for a little bit.
Yeah. So episodic means episode. What exacerbates is just a medical term, means worse. Okay? So these episodes, we're about to get into another episodic thing where pretty soon we're going to start turning our heaters on. So we get all that dust and all those dust mites and all that stuff coming out of our vents. That's going to cause asthma attacks. In a couple of weeks, there's going to be more asthma attacks. What happens in a couple of weeks?
Winter.
Gets colder.
Now you guys get your report cards.
Oh, yeah.
I've seen teenagers, the true asthma attack because of their grades and their confrontation they're having with their parents over their grades. Breakups, boyfriend, girlfriend breakups, boom, asthma attack. But changing the weather causes asthma attack. Allergic reaction, could cause a asthma attack. So whatever the episode is, it's the same. You get this bronchial constriction or bronchial spasms, and it constricts the bronchioles, so there's not ability for air to get in, but not air to get out. That's where you get the wheeze or the air trapping sound from. So there's a good picture over you look at the bronchioles, they got all this fluid accumulation, they got the bronchoconstriction going right through here, and then swelling. So you have sort of three things in an asthma patient that's taking place. You have bronchoconstriction, or bronchospasms. You have mucus production, and then you have swelling of that bronchiole, which is going to cause bronchial constriction. So those are the three things that you're fighting against to get this person breathing right. The good thing about it is, like Nissan said, you get this albuterol or Ventolin or albuterol, and it's a Ventolin or albuterol is a bronchodilator. That's the class of the medication. So you get that, and it bronchodilates, and it opens that passage up somewhat, so you get more air in there. Sort of like nitro does to the coronary arteries. Okay, that albuterol is a bronchodilator. Now you have what? The swelling and the mucus, right? What about the mucus? If they give a drug that we may mention later with albuterol, they call it A&A. You'll see this when you go to respiratory. Give it A&A. They give albuterol and a drug called Atrovent. Atrovent is in the family of atropine. Astral vent, like astros and vent. Atrovent dries secretions. That's why you give it. It's not a bronchodilator. It may have a little bronchodilation effect to it, but you pour it in there and it dries up the secretions. So you're bronchodilating. You give the Atrovent for the secretions. Now what about the swelling? What do you think they give for the swelling? No. A steroid. So they give the patient a steroid to reduce the swelling. The problem with the steroid is it takes a long time for that to kick in. So they pump them full of these bronchodilators, they give them the steroid, okay, and then they send them home. Now a lot of the asthmatics, they're already using the albuterol. So if you go in an asthma thing, you start using the nebulizer or the handheld inhaler, yeah, that's right. You start using the inhaler. The problem with the inhaler, usually the asthmatics, their respiratory rate's up. That's one of the signs of their respiratory rate's up. So they use the inhaler, they go. So that powder form gets to about their hypopharynx and they blow it back out. The same way with what we're learning as a nebulized treatment, you put the mask on them, you still have to coach them and say, take a deep breath and sort of hold it in. You know, take a deep breath, hold it in, to get that medicine down into the bronchioles. So the treatment here, oxygen, all right, albuterol, which is the bronchodilator, Atrovent, which is to dry the secretions, and then steroids. Those are the things that you're going to see with the not only the asthma patient, but the emphysema patient. The same thing. Chronic bronchitis patient, same thing. So the treatment is across the board about the same. Everybody good with the asthma? I mean, again, this is just sort of an overview, what you see. But questions? Everybody good? All right. Coming back up to the winter months, pneumonia, bacterial pneumonia, viral pneumonia. Could be something in there causing an infection. You just got these microbes growing inside the lungs. All right. And you get pneumonia. Elderly people, again, I don't fit in that category. They struggle with pneumonia. They get pneumonia, and that's a big thing. It's almost could be put into the ICU with pneumonia. I had a friend of mine that almost died from double pneumonia. All right, so it's a huge thing. Viral pneumonia, you might hear walking pneumonia. So you go in, they do a chest X-ray and say, yeah, you got a little pneumonia there. We'll give you some antibiotics, but it's not that bad. Bacterial pneumonia, you got to be in the hospital, IV antibiotics. I think, yeah, here it is. The chest X-ray, they shoot a chest X-ray. And when you look at this black area is good. That means it's clear. You got a small spot here or something, okay, but probably insignificant. But you look at the right side, look at in this area right here, this white area, it's the pneumonia. If there's double pneumonia, then they'd have it over here, correct? They'd have it in the left lung as well. Sort of see the heart, outline of the heart. This person doesn't have CHF, right? Heart's normal size, looks normal. If you look here, the ribs, different ribs, and then what's important, I want to point out on this X-ray while we're here, see the clavicle? Yeah. Right up here. First rib. You can't palpate the first rib. The first rib is under the clavicle. You can't feel it. The first rib that you feel is the second rib. And then the intercostal spaces as we go down. If you would have looked close, you could see the trachea on there, but not necessarily on here. So there's a lot that you can pick up from the X-ray, but we're primarily looking at this pneumonia. And that's a lot. That's a large surface area. Yeah, that's a lot. So this guy's going in the hospital here with pneumonia. The difference is that they don't have the difficulty breathing. They may have the wheezes, right? You may hear some fluid because of the pneumonia. Right? But what do you think is going to be the difference between, let's say, an emphysema patient and a pneumonia patient? What's going to be the key sign that you can say, yeah, I think he has pneumonia instead of emphysema? Both are smokers.
One has a pneumonia.
Would someone with pneumonia cannot breathe on a oxygen mask?
No, it has nothing to do with that. Key sign. Key sign. What's a sign?
Oh, something that you can see.
Something you see or measure. You want me to give you a hint?
Pneumonia has micro.
Can't hear you.
Cause inflammation. Based on the lungs, you can see that.
Let me give you a closer
You
hint.
get inflammation. That's what I did. What? Not, she's quiet.
Bacteria. Why reason from inhalation?
Oh, from, I got it,
Think about it. You have let's say you have bacterial pneumonia. What is a sign that you're going to have that you're not going to have with emphysema?
It's an infection.
When you get it back, when you get strep, what follows strep? What do you always have with strep?
Fever, coughing.
Fever.
Oh, I said that.
Alright? You're going to have fever. This person with pneumonia is typically going to be febrile. Right? So they don't have fever associated with the pneumonia. Right? They may still have the wheezes in the bronchi. You may get some wheezes in here because of this big mass here. They could get now this fluid in here. This is not rails. That's important to know for a later thing. Not necessarily for you guys. This is just FYI, so you look really good when someone asks you, okay? This is not rails, that's pneumonia. That's fluid, okay, but it's not it's a fluid built up by the infection, the bacterial stuff in there. So when you hear this, you hear fluid. And to discern the difference between rails and the pneumonia, besides the fever and the productive cough and all those other things, okay, you can listen to breath sounds over the trachea. It has a big name called, I don't know, tracheobronchial something sounds, okay? You can listen to these, and you get that sound, and you go over here and listen to this, and this sound are the same. That's telling you that that's a pneumonia instead of, like in CHF, Lasix, bronchi, rails. The overall problem with that is, here, one of the medications you give for CHF is what? Lasix. Lasix is what? What class of drug? Yeah, I want to go PP drug. It's a diuretic. It's going to, and it's not one of those things, when you take Lasix or give Lasix, it's not one of those things that, oh, I have to use the bathroom. It's been an hour now and a half. Okay? It's like, stop and go. There's a huge urgency to go to the bathroom. That's why when they give patients Lasix, they usually put a Foley in, because it's a really strong diuretic. If I took Lasix, IV Lasix 5 minutes from now, I'll be going, whew, hold the boat, got to go. There'd be no waiting around. The thing with that is if I give Lasix to a pneumonia patient, I'll probably kill him. So see the importance of discerning the two signs and symptoms, right? You really have to, before I gave any Lasix and I suspected maybe a pneumonia or CHF, I'd get a chest x-ray, if that was a possibility, and look for a pneumonia before I give Lasix. Now, pre-hospital, like in my environment, I still have to know the difference. So again, I compare the signs and symptoms, right? If they're febrile with a productive cough, there's no way I'm giving them Lasix, because they may have a pneumonia. Right? And it would look bad on my resume to have that death put on there, right? One killed because of stupidity. You know, it's only one mistake, right? Unless it's your family member, then that's probably a little bit worse mistake, right? All right, so treatment, oxygenate them, you know, supportive care. In the hospital, you'd start them on antibiotics, right? Just sort of support that. The last one, I think, no, we got two more. Okay. Spontaneous pneumothorax, we talked about that. Very high in smokers. One of my ex-students, she's coming to class. Her mom was a heavy smoker, had a sudden onset of difficulty breathing. Fortunately for her mom, the student was a listener. Right? The parent goes, "Oh, I'm just having trouble breathing. I'll take care of it later." And then the kid made her pull over at the fire station. He goes, no, you pull over at the fire station. We need to get this checked out. Pulled over, decreased lung sounds to that affected side, took her to the hospital, had a pneumothorax or a collapsed lung, maybe what you guys are a little more familiar with. So she had a collapsed lung, which a simple pneumothorax or a spontaneous pneumothorax is not necessarily a life-threatening condition like a tension pneumothorax we'll learn about later, but it is a true medical emergency. They had to go in and put a chest tube in her and drain off that air. So fortunately for her, her daughter was a listener because she listened that difficulty breathing is a problem. All right, and then they picked up on this pneumothorax. Then all was fine. She got out of the hospital a couple of days. You know, took her daughter out to ice cream. No, not really. I don't know. Okay, but the collapsed lung. So when you see this pneumothorax, sharp pleuric type chest pain, decreased lung sounds on the side or absent lung sounds, shortness of breath, dyspnea, right? Maybe late signs of cyanosis. Put late out to the side, very late sign of cyanosis. The tachycardia would be because of all the difficulty breathing. Remember, shortness of breath, heart rate, respiratory rate, heart rate, proportional. All right. Here's with here. These are the main two things that you'll see: decreased or absent, mainly decreased breath sounds. So you get decreased breath sounds on one side, or that pleuric type pain. Has anybody ever had pleurisy? Pleurisy is an infection of the pleural space. Remember, you have, back to a little anatomy, you have the visceral pleura that covers the lung, and the parietal pleura that covers the thoracic cavity, and then in between that you have the pleural space, which is filled with what? Fluid. Filled with serious fluid, not like serious fluid, but serious fluid, sort of a lubricant. So when we take a deep breath, those two pleural spaces go like this. They move up and down. What happens is people get an infection, pleurisy, there, and they say, every time I take a breath, it hurts right here. That's where the infection is. It's this sharp, sort of like you're stabbing me type pain there. And that's one a hallmark sign of pleurisy. Infection would mean also what? Infection, what comes with infection? Fever. Always. Gotta always get a little infection. That's the body's way of trying to kill it. So you get this pleuric type pain is what this means. It's just really sharp, pinpoint, like I just stabbed you with a knife type pain in there every time I take a deep breath. So either you have to discern here, do they have a pneumothorax or is it pleurisy? Will they have fever with the pneumothorax? No. So they need to go to the hospital. They do most all the time require a chest tube to be placed in. Give them high flow oxygen. CPAP is contraindicated. You can just cross through that. We're not going to really learn about CPAP right away. Maybe later we'll pick up CPAP. You'll see it in the hospital. It's pretty cool. Put this huge mask on them and it forces air into the lungs. Now, why would CPAP be contraindicated? If it forces air into the lung, why would it be contraindicated?
And the lungs collapse.
Yeah, right. The lungs already collapsed. You're forcing air into that pleural space and not into the lung. So you don't increase the size of the pneumothorax. And this should be the last one. I hope. I'm having difficulty breathing. Yeah. So we have a pulmonary embolism, high mortality rate, pulmonary embolism. I can't remember. I've seen people survive a pulmonary embolism. I've met them, but they've never been patients of mine. Either I'm really terrible at what I do, or it has a high mortality rate. All right. A pulmonary embolism, we know what an embolism is, right? Embolism is something that breaks off from the body. Like say you have that heart attack, they go in and do that stent, and that plaque breaks off, and it travels out of the heart and then ends up into the lungs, right? So you have that embolism sort of floating through there, now it gets stuck in a pulmonary capillary. So it causes what it causes here is what's called a VQ, V as in Victor, Q. V for ventilation, Q, mismatch. V means ventilation, Q stands for perfusion, causes a VQ mismatch. What that means in English is that the oxygen that you're pumping into them is not doing any good because they can't use it. They have this mismatch between their ventilation and perfusion. They're not going to use it. That's the way that I understand it. I mean, I know it's a lot more complicated. Maybe I'll get somebody from respiratory one day to explain it to me. But you have this VQ mismatch. What this equates to me is severe respiratory distress. These patients are sitting upright, boldly upright. You're giving them a non-rebreather, you're flooding them with oxygen, and it's not doing any good. Now, what is one very serious complication of a pulmonary embolism, besides the breathing? Exactly. You could have a heart attack. And that's probably the way most people die from this, is they're having such difficulty breathing, they have an MI. And then they have an MI secondary to a pulmonary embolism. Okay. But it could also come from a deep vein thrombosis, just breaks off there. This is why they tell you if you take long international flights to get up and walk around, because your legs are clenched all the time. You don't want that. You got to get up and get good circulation. Make sure that you have good circulation, because you could get this thrombosis here, this clotting. All right. And look at that. There's sort of a picture, a good picture of it. This embolism here, this is a capillary, pulmonary capillary, and all of a sudden this broke off from somewhere else, got through the heart. If it lodged in the coronary artery, what would it cause? could cause an MI. Lodged in the pulmonary artery, it's going to cause a PE or pulmonary embolism. Still could cause an MI, but it's don't cause a pulmonary embolism. I had a video of them digging one out. It was pretty cool, but it didn't work. I have to go find it again. But so they'll get this pulmonary embolism out if they get to it in time, if it doesn't kill you some other way. So very, very frank respiratory distress, once you see it, you come up to the patient and they're having all this difficulty breathing, they're breathing like crazy, they're breathing 40, 50 times a minute, they're diaphoretic, they're cyanotic, you're pumping them full of oxygen, they're sitting bodily upright. The thing that should key off in your mind is pulmonary embolism. All right? And then they need to go to see that cardiothoracic surgeon to get this removed. And if they don't, then in time is of the essence in these pulmonary embolisms. They need to go somewhere that has a chest cutter. Someone can operate on them pretty quickly. So, chest pain, low sats, tachycardia, get some wheezes in there, just all the normal difficulty breathing signs, especially the low saturations. Remember VQ mismatch, their sats are going to be really crummy. So and you're pumping them full of oxygen. You can't figure out, I got this non-rebreather at 1,000 liters per minute, and just can't get it 1,000 liters per minute. You just can't figure out why they're not responding to the oxygen. So it could be an embolism with those. Oxygenate them. Make sure that you try to get them to the right place. And it's very hard to look at. When pre-hospital wise, it's very hard to look at. Is this in response to an MI? Because they could be having multiple problems. They could be already having the MI, so do the 12 lead on them, and it's showing this global MI, this big MI, and they're having this trouble breathing. So you think, oh, it's STEMI, right? So you start treating for STEMI, and you're looking at that MI, and then all of a sudden, they're having a PE. The PE caused the MI. So one of those things. But does it really matter in the end? Because you're going to treat them for both. You're going to treat that respiratory problem, and then you're going to treat that. Got to treat that heart attack issue as well. Right, we'll look at this after break, right quick. This nasal small meter dose nebulizer or nebulized treatment. You guys who've already been through a rotation with respiratory, did y'all do any nebulized treatments? Breathing treatments? Has any of you guys went through respiratory?
No, we didn't.
Y'all do any breathing treatments? No? Okay.
Did you?
They put the mask on and creates this mist.
Yeah.
Okay. Then they give them a breathing treatment. Inside that mist is the albuterol that we talked about. They breathe in these vapors. So the nebulizing part is the oxygen running through the fluid, and it creates this mist, and they breathe in this mist. They breathe it in, it goes into the lungs. Of course, remember that albuterol is a beta drug. Beta 1, we talked about that, right? So what's it going to do? Beta 2 is going to cause dilation to lungs. So it's a beta 2 drug because it's a bronchodilator. It's also a beta 1 drug. 1 equals the heart. So what's it going to do to the heart? Right, it's going to increase the heart rate. So now you're looking at this medication that you're giving. It increases, it's a beta 1, beta 2, so you're going to get bronchodilation. That's what you want, but it's a beta 1 drug. So now you have it's going to increase the heart rate. So what's the contraindication for albuterol? Right, someone that already has a tachycardia. In this, tachycardia would be, because they're going to be tachycardic anyway, because they're hitting on their their inhaler and all this other stuff. But we're talking tachycardia over about 150. So if the heart rate's over 150, you don't have to reconsider something with the albuterol. Until it gets about 150 in a young person, I would fit in that category. About 150. 150, you're going to have to reconsider something. You get that heart rate up too much, an older person, you're going to give them a heart attack potentially. Or at best, you're going to start decreasing cardiac output with it. You don't get them too tachycardic. Just for your information, a heart rate above 150 has a different name. Because a tachycardia is what? Above 100. Any heart rate above 100 is considered a tachycardia. Any heart rate above 150 is considered a supraventricular tachycardia, or an SVT. Supra means what? A what? Above, right? Above. Supraventricular tachycardia. So it is greater than 150. So albuterol and SVT would be, if you got a heart rate of 150, you still don't have to treat them. Fortunately, there's drugs that are what's called beta-2 selective drugs. What would be a beta-2 selective drug? Right. It works only on the lungs. There's no beta-1 in there. So it doesn't increase the heart rate. It's beta-2 selective. It only does the bronchodilation. Everybody good? Again, I'm not trying to throw a lot of pharmacology at you guys, but you're going to hear this stuff in the hospital. You need to know, especially with respiratory, you need to know what they're talking about, right? And then there's albuterol or Ventolin, and we'll look at this after break. I'll hook one up and show you how it nebulizes. Everybody good? A lot of information, but fortunately the treatment's all the same.